also the other thing that you can do is with good contrast enhancement, interrogate the enhancement pattern of the intestinal wall. Especially hypoperfusion is important and often associated with surgical lesions. So if you see any one of these, or a combination of any one of these specific CT findings, you can confidently ask your surgeon to operate, because the patient has a surgical bowel injury, and you will be right. Let's look at some examples. This is an old CT scan of a patient who was kicked by a horse. This is a conventional CT. The reason why I'm using it, it has all the signs of intestinal injury, which you're not going to see in a hurry. And what you're seeing here is large amount of free intraperitoneal gas, and this particular patient did not have a pneumothorax or pneumomediastina, no bladder injury, surgeons did not intervene. So this is coming from a hollow viscous injury. And there is also fluid around the pancreatic head. And here are 4 images more inferiorly. You can see the second part of the duodenum totally ripped off from the head of the pancreas. So this is a grade 5 pancreatic or duodenal injury. And you can see the common bile duct nicely sitting within hematoma. You can see polar contrast material superstition, and there is large amount of free intraperitoneal fluid. Again, the surgeon was concerned that the patient did have either a pancreatic or duodenal injury. The patient has both. The diagnosis was made, communication was established, and this patient had a relatively good outcome for a grade 5 pancreatic or duodenal injury. Here is a kid, which is unusual to come to shock trauma, who had an abdominal CT showing free intraperitoneal fluid in the right paracolic gutter. Lots of areas of colonic wall thickening involving the transverse and ascending colon, mesenteric stranding, and then free intraperitoneal gas. And again, the criteria were fulfilled. Gas was not decompressing from the chest, no bladder injury, no interventions. The surgeons were told that this patient has a full thickness injury, and here is the pathological correlation. Patient had to have a hemicolectomy for this injury. And you can see there are multiple areas of bruising or contusions in the large bowel wall. And also, what you can't see on the first specimen is there is a hole at the hepatic flexure, full thickness injury, through which the surgeon is introducing a finger, through which the gas escaped into the peritoneal cavity. To demonstrate very small amounts of gas could be seen on good quality CT. The predominant findings here is multiple jejunal wall thickening seen in multiple images. That's the predominant finding. If you look more carefully, there's interloop fluid, which is concerning. And then there is one single bubble of gas sitting anterior to the thickened abnormal jejunum. And always use your reformatted images, and you can nicely confirm this bubble is extraluminal. And based on this, the radiologist who was looking at this case told the surgeon he has a full thickness injury and you need to operate, and he was right. Here is a patient who has focal thickening of the distal descending colon, stranding around the injured colon. But what you see on 2 different rendering techniques, there is a defect in the medial wall of the colon. And you can see gas escaping into the retroperitoneum through the defect. And when you change the windows, you can see even fecal material spilling into the retroperitoneum. Again, a surgically confirmed case. Here is a patient, admission CT, who has extensive pneumatosis. The pneumatosis is in the cecum. It's also in the distal ileum. Reformatted images confirm your findings. When you have this amount of extensive pneumatosis, on your admission CT, you can confidently tell the surgeons to operate. And this ended up as both. There was an injury, a full thickness injury to the cecum, and there was also an addition an old case when we used to give oral contrast material. And you can nicely see proximal jejunum is thickened, oral contrast material is extravasating into the peritoneal cavity, and here is the operative specimen showing two holes through which the oral contrast extravasated into the peritoneal cavity. So if you give oral contrast, you may see this. But I think with the quality of CT improving, less and less people are using oral contrast to opacify bowel. Here is a case where communication became so important. This was a patient who was involved in a motorcycle accident, had a deep gloving injury of his right lower extremity, and the gas that you're seeing in the pelvis with a few bone fragments was due to the lower extremity injury. The surgeons did a fast because he was quite ill, and they were very much interested treating the lower extremity injury because outcomes are better if you treat these open compound fractures quickly. And they did a fast, and it was negative. They did the CT, and they thought that the CT is going to be negative, and was about to sort of take the patient to the orthopedic. The patient was going to be taken over by the orthopedic surgeons. The radiologist who looked at this CT scan realized that there are areas of ileum which is not enhancing compared to the normal enhancement of the ileum. And when you look more carefully, there are even areas of ileum which is partially enhancing. The posterior aspect of the ileum is enhancing, but the anterior aspect is not. These are important findings. And also, if you look more carefully, there is discontinuity, and that loop of ileum is not going anywhere, and the sulcus entericus is spilling into the right iliac fossa. So the radiologist ran up and said, by the way, do you know there is a full thickness intestinal injury with areas of devascularization? The whole plan changed. So the patient was initially taken for laparotomy, and then his low extremity problems were sorted out by the orthopedic surgeon. So it's very important to communicate. There should be good communication between the radiologist and the surgeons. So let's look at non-specific MDCT findings. There are two of them. You can look for intestinal wall thickening, and you can look for free intraperitoneal fluid. Here is an old study that we published in the Journal of Trauma. The only number that doesn't stand the test of time is the sensitivity of free air. It's about 30 to 40%, I think, in the current literature. And you can see we are looking at 4 different signs: free air, free fluid, bowel wall thickening, and at that time we used to routinely give oral contrast material. And you can see the two specific signs have very poor sensitivity, but a good positive predictive value and specificity. Whereas free intraperitoneal fluid is the most sensitive CT finding of intestinal injury. And you can see, if you just, based on that alone, if you send the patient to surgery, nearly 30 to 40% of your patients will have a therapeutic laparotomy, but majority of the patients are going to have a negative or non-therapeutic operation, an unnecessary operation. So, what do you do when you see a non-specific CT finding? The important thing is, since there are all these options, I think it is important for the radiologist and the trauma surgeon to communicate and see what's going on clinically and what's going on radiologically. And if that's the case, based on what your practice is, you will make the right decision. So the options that are available is that you can serially examine the patient over a period of time to see whether the patient is developing peritonitis. You can do a follow-up CT, and at our institution, this is a very popular item because the surgeons are busy, they don't have time to examine the patients. And if you're going to do a follow-up CT, it's very, very important that you tell your clinical colleagues to administer the oral contrast material soon as the decision is made. And the follow-up CT should be done with oral contrast material. Even in the best circumstances, I may be able to show you a case where we did a follow-up CT without oral contrast material, but luckily we managed to get the correct diagnosis. Diagnostic peritoneal lavage, it is a dying art since the introduction of ultrasound. It is an option depending on the time of injury to time of CT. As more time goes on, the likelihood of the DPL becoming positive and having a high positive predictive value increases. So that is an option if you have a surgeon who knows how to do it. If you have a surgeon who can perform laparoscopy, if you can specify which region you are worried about by CT, then laparoscopy may have a role. And lastly, I think there is nothing wrong in performing a laparotomy in the right clinical and radiological setup. So the next few cases that I'm going to show you are going to bring out these points that we discussed on this slide. So here is a patient who has a clear-cut seatbelt injury. There's no hiding seatbelt injury. And here are the CT images that were seen on this patient who was hemodynamically stable. And what you're seeing is there is definitely loops of thickened small bowel. There is mesenteric stranding. There is fluid on either side, intraperitoneal fluid on the left and retroperitoneal fluid on the right. So with these, there's no free air, there's none of the other specific CT findings that we talked about. So what do you do? So we went and talked to the surgeon. And the surgeon was also concerned about this patient, that the patient was having decent amount of abdominal pain, and a decision to perform a laparotomy was undertaken. And here is what they saw at laparotomy. There are two full thickness transection of small bowel. That's a 2-layer rent in the mesentery. And all these are surgical lesions. And the only reason why this patient was taken to surgery at the correct time, before peritonitis setting, was the communication between the radiologist and the trauma surgeon. Here is an outside study that was done. The patient was transferred to us at about 6 hours. The surgeons were quite keen to operate on this patient because he had what they thought as a bladder injury, and what he has is pelvic fractures with extraperitoneal hematoma, no active bleeding. And also what you see is the Foley catheter is sitting extraperitoneally, and you can see the Foley catheter entering the retroperitoneum through a defect in the bowel. What was not mentioned at the outside institution is that there were additional free intraperitoneal fluid and lots of loops of small bowel wall thickening, and it's about 6 to 8 hours, and the question was, should they operate or should they rescan the patient? There is no clear-cut answer for this. Either could be right. If you believe that this is full-thickness bowel injury, then you can operate. You do not need to operate for the bladder injury, which they thought, the surgeons thought, but once you told that this was extraperitoneal bladder injury, they withdrew, and they were happy to rescan the patient, and they rescanned the patient at about 6 hours. And here is a case where we forgot to give oral contrast material, but the CT did answer. You can see all these loops of ugly-looking small bowel is now looking normal. And what we also did is a CT cystogram indicating that there is no combined bladder injury. If there was an intraperitoneal injury, the surgeons needed to operate on the bladder. But we did show the surgeons that this is an extraperitoneal injury, and the patient was managed non-operating. Here is a patient who has large amount of free intraperitoneal fluid in multiple compartments around the liver, spleen, in the paracollic gutters, in the pelvis, even in the mesentery. lots of loops of small bowel thickening. And when we reconstructed the spine, he also had a chance fracture. He did have abdominal pain. Based on the extensiveness of the free intraperitoneal fluid, the chance fracture, and the abdominal pain, surgery was performed and he had a surgical lesion. So this was a therapeutic laparoscopy. Here is an interesting case. Patient who had an industrial accident, a heavy weight had fallen on his right iliac fossa. The patient had no symptoms. You may ask them, why did you do the CT? But the indication at our place to do a CT is presence of an abdomen. And you can see this is an old CT where we gave oral contrast material. And you can see the main abnormality is the cecal wall, eccentric cecal wall thickening. And one of the junior radiologists thought, because he had no symptoms, whether this was a cecal mass. It's causing mass effect on the contrast material within the cecum. And you can see even mesenteric stranding. And the senior radiologist, trauma radiologist, thought that why can't this be just a hematoma? And the surgeon who was taking care of this patient was quite good with laparoscopy. So the option was for him to have a look with the laparoscopy, and if there is an injury that needs to be dealt with, then he will convert the laparoscopy to laparotomy, and this is what he saw. So when he went in, already you can see the cecum, there's an area of necrosis. And it's interesting, being retroperitoneal, the patient did not have much symptoms, and a hemicolectomy was performed in this patient. Here is a similar patient. The difference is the last patient had eccentric colonic wall thickening. This was a patient who has concentric colonic wall thickening, and there's no hiding. There's contrast material. The cecum is definitely thickened. This is abnormal. If this is not abnormal, I don't know what is normal. And in this particular case, when we were concerned, the radiologist was concerned that this will be a bad cecal injury, having had the experience with the last case. But the surgeon was quite confident, saying that I have time, I will examine the patient, I'm not going to operate because he does not have symptoms. We went ahead and repeated the follow-up CT, and you can see nicely the follow-up CT, again, with contrast material. The cecal wall thickening is starting to decrease, and this patient was managed non-operatively. Again, just goes to show why intestinal wall thickening could look ugly, but turn out to be, it resolves on its own. It's not a full thickness injury. So I think this is where I think when you have a non-specific CT finding, it's very important to talk to your clinical colleagues and try and make the right decision. An example of a patient who has changes due to rapid volume resuscitation. You can see that the patient has periportal edema. These are the lymphatics within the portal system showing up because they can't cope with the volume that has been administered rapidly. A markedly dilated vena cava, which is much bigger than the aorta, and diffuse small bowel wall thickening. And the important thing to remember here is once you stop giving volume, this will disappear in about 45 minutes. But if the patient has abdominal pain, always do a repeat CT with oral contrast material. To contrast that with the situation where if there is hypovolemia, what is called as shock bowel, see the difference. The vena cava is collapsed, the arterial tree is in spasm, there is slow circulation through the splanchnic circulation, so bowel wall is enhancing profoundly, kidneys are enhancing profoundly, and again, patient has a retroperitoneal hematoma due to pelvic fractures which was bleeding, and that's why the patient was hypotensive and under-resuscitated, and that's why we are seeing changes due to hypovolemia. So, I think at this stage I'm going to wind up. So what we did in the given time today is we looked at a spectrum of findings seen with intestinal injuries. And what we did was divide these findings into specific and non-specific findings, and show you if you have a specific finding, you can confidently tell your surgical colleagues that they need to operate. And if you have the two non-specific CT findings, I think it's very important for the surgeon and the radiologist involved with the patient to communicate, discuss the findings, and make a